I must say that this is my first, this month, every month I try to give a lecture or sit somewhere in the podium. And the last two podium invitations for me were to uh, give graduation day awards to kids from the age of upper kindergarten to 12th standard. I really enjoyed it. There were 660 students who received awards from me. So that was, and the second one was in another school where the martial arts, and I had known nothing about martial arts except that my wife is also a martial art black belt graded person. So I live in a very dangerous situation at home. So I'm very happy to be here amongst youngsters like you, and because that is what challenges me. AMR is something that I worked on for the past 20, maybe 30 years as such. Honestly, I didn't want to work in AMR. I was in Los Angeles at the time when HIV/AIDS broke out. And I told my chief, sir, I don't want to study anything about HIV/AIDS because HIV is not going to come into my country. And behold, when I returned, HIV had also returned into the country. I didn't bring it, but HIV came. So now, my PhD, my basic medical sciences is with looking at hospital-acquired infections, ESBLs, MRSA, etc. And then grew my interest in AMR. Now, having said this, I've got 43 minutes left for me to give you this talk on what I think is important for you youngsters. I've got another 20 more years of lifespan, maybe health span as well. I look forward to that, and I invest myself in fitness and energy building. But the message to you is you will have a longer lifespan and probably a health span than me because things are advancing. But you, not me, will die of antimicrobial resistance causing infections. You have to be very careful unless you spearhead it. My grandson, who's studying in Mahi campus here, will not have any antibiotics left available for him. Having said this, I want young innovators to understand where we stand today, how we began, who made it, who is responsible, why are we continuing in this Kolavaridi, I don't understand. So having said this, this will be the outline of my talk, trying to give you an understanding of the magnitude of this problem. I've been through the abstracts yesterday, this morning from the abstract book. You may have had some introductions. I'm not going to repeat it, but I'm just going to reinforce or re-emphasize what the previous speakers may have done and how you should take things forward. So this is the outline of my talk. Now, having said this, let's look at, try to understand this antibiotic function. It's a very dynamic thing. If you don't have antibiotics, there is no antimicrobial resistance. If you don't have bacteria, virus or fungus, there is no resistance in organisms. So if you are naming an organism and shaming the organism, that is killing it by using an antimicrobial agent. In society, if I do that, will I tolerate you? I will develop my own defense mechanisms. And you can't blame the organism. You can't blame the bacteria. They were here before us. So they would like to survive more than you as such. So you must be careful on this. So it's the pressure on the bacteria to survive that is resulting in antimicrobial resistance. The world from the time of Alexander Fleming's discovery of penicillin, I'm not worried on the, that we have got about 20 different classes of antibiotics. Now, with these 20 different classes, okay, we are not able to curb the antimicrobial threats in our hospital. Now, you might think, let me discover one more. Brother, even if, or sister, even if you discover one more, you are not going to, you don't have the science to preserve the life of that antibiotic. I'm very happy that today, in the mid-2025, that penicillin is useful and it's very active against MSSA, methicillin susceptible Staph aureus. And who amongst us uses penicillin. I believe in penicillin. Unfortunately, India has stopped manufacturing penicillin. They will start remanufacturing once they find that penicillin, it's not a broad spectrum, it's a narrow spectrum antibiotic. That is the answer to the community acquired staph aureus infections that we see. So having said this, I don't think we need more and more antibiotics in the pipeline. Learn to manage with what we have. We need more antivirals, we may need more antifungals as such. So having said this, I have written this book on management of infectious diseases. There are 135 syndromes where we give antibiotics for patients who have manifestations of an infectious disease. But nobody reads it. I have not published the next edition simply because it is changing. The antibiotics, what I wrote in 2012 is different from what we need in 2025. So try to understand that. So it is a changing phenomenon. Now look at India. Don't look at the West. We can follow the West in several. We have a fifth of the world's population, a fifth of the world's deaths, occur in India. Of course, when people are born, people have to die. Today, if a child is born, there's 72 years of life expectancy. And so having reached the age of 72, you've got another 13 more years. Once you reach 86, you've got another 6 more years. You have to look at life expectancy in that format. And then you need to maintain your quality of life. I'm very worried. I don't mind going like this, but I don't want a disability. I already have a disability in terms of my hearing because I did deep diving and perforated my eardrums. So one has to be careful about what is disability associated life and what is longevity. Having said this, when we used to teach, predominantly it was infectious disease, non-communicable disease, communicable disease, infectious disease. Now non-communicable diseases have come up. Infectious disease still remain. But please remember that those with non-communicable disease, if they die, they will die of infectious disease. So you can't get away from the study of infectious disease. You can't get away from the study of microorganisms, 3,500 microorganisms, and only depend on how many pathogens should you really understand and what is priority for you, we'll discuss that. Now you come to the hospital setting. People come to the hospital only because they cannot they cannot have support at home. And secondly, hospitals are very expensive. And if you look at it, only 15% of people die in hospitals, 85% die at homes. My parents died at home. My parents were 98 and 88. I managed to care for them at home because the reason is you don't need that kind of an expensive treatment. You can get oxygen cylinders at home, you can get home care, but insurance doesn't provide home care support. What I'm trying to get at is people who come, I handle quality, patient safety and quality in my hospital. Every month I have 12, this month I have 20 deaths, previous month 8 deaths. 6 on 10 sepsis. 6 on 10 is sepsis, 2 is road traffic accident. And the only way you can die is if you get a head injury. Now with crash elements you don't get that, you don't get death, but you get disability coming on. So, and then people are managing with devices. So devices, sepsis are the reasons why people come to the hospital. Of course you have osteoarthritis, you have got coronary heart diseases, etc. So, and sepsis is very expensive for diagnosis, for treatment, and for also bringing the patient outside of the hospital. So in the hospital, either you come with an infection and get treated, or you get an infection within the hospital also. Now we do procedures. If we are not careful about our infection control practices, we cause infections to the patients. So hospital is really not a safe place unless you have got an emphasis on infection prevention and control. Unless you have an emphasis on making sure that there is no significant antimicrobial resistances. Imagine 7 out of 100 hospitalized patients. This is in high income countries. And they're saying in India 10 out of 100 hospitalizations, maybe more, maybe 15. But I don't want to extrapolate without data. But this is what the data, I've given the references also. 7 on 10 on 100, that is 10%. And now whether you're hospitalized for 4 days or 5 days, I've not given you that calculation. But I'm saying that you will find, and in developing countries, we estimate that there will be 2 to 3 times more than in the developed world. Studies have been shown in King George Hospital, 20% had hospital-acquired infections. We did a study in Pan-India, 35 ICUs, and patients over 45% were caused of the sepsis prevalence. Sepsis, of course, sepsis 1, sepsis 2, sepsis 3, don't worry about that classification. Sepsis was found on one given day, May 17, 2021, to be 56% of the patients admitted in the ICU. That means, you see that it's a very high. And 45% of them were due to MDR, multi-drug resistance. So you have resistance, you get hospital-acquired infections in ICU, and you have resistant bacteria in the ICU, in a closed entity, and spread is also possible. We're talking about spread into the ecosystems and other things, but spread into the ecosystem of your own hospital. Now, what are the types of hospital-acquired infection? Surgical site infections, that is on the site of surgery. Now that is why with all this minimally invasive surgery and probably robotic surgery, the incision size has also come down. So therefore less chance of tissue disruption, perhaps lesser chance of infection, but you've got to disinfect the scopes. You make sure that you practice antisepsis before you insert the scopes into the abdomen and things like that. And mortality is also high, because in the previous slide I showed you the Indian mortality is also high, 27%. And mind you, there's word, I hate it, Lama Dama. Lama means left against medical advice, Dama means discharged against medical advice. Simply because they are going downhill, simply because they don't have financial money to control to treat. What do you do if I don't have money? I have to sell my property to treat my father or etc. So what happens is, so I'll take Dama. But they're having sepsis. But sepsis can be reversed. It's only a physiological state. It can be reversed, provided you hit the right bug and with the right drug. Now, I started my work 2001. Let me begin at that time. I did not know the spelling of ESBL, but I took it up as my research topic. MRSA, Pseudomonas aeruginosa, Acinetobacter baumannii. I used to teach my medical students, don't learn any 4-letter words, but learn AU, Acinetobacter baumannii, AU, Pseudomonas, okay, so that at least you will learn the names of organisms as such. So, when I started my research, of course, I liked microbiology, I liked pharmacology, so it was good for me to get into infectious diseases as a specialty of interest. And you see, I did global surveillance. I was also wondering, why am I doing all this global surveillance? But I wanted to learn all the techniques. I wanted to learn how to do how to do typing, how to do AST, how to understand the new methodologies for looking at just out of curiosity and interest. And then I worked on my PhD on that. So, the world had very little ESBRs. India had 50% at that time. That means gram-negative organisms in my country in 2001, were 50% of them acquired in our hospitals in India. 10 medical centers were carrying ESBRs. At that time I knew SHV1, SHV2, TEM, TEM2, very, very fundamental knowledge about it. Later on it expanded into so many, I think there are more than 150 ESBRs available, going on now. Very honestly, I want to be very truthful. When I collected my samples in 2001, 2002, I found carbapenemases, but I did not know about metallobutyllactamases. In fact, my publication came before the other publications. They are the first ones to term it as metallobutyllactamase. And this metallobutyllactamase was discovered in India, and it has spread all over the country as to other countries in the world. So I'm not saying New Delhi metallobutyllactamase we gave to the world. How it came into India, how created it, I really don't know. But it has spread. We discovered it in India. So having said this, if we have emergence of that, at that time we had only NDM1. Today we have NDM7 and in transfer to other organisms. I don't know where it is coming from or what we are doing to the ecosystem in our country. When we discovered it in Delhi, we discovered it in different parts of the country. So it was there already. When I looked at people who have not received antimicrobial agents and looked at their fecal stools, I found ESBLs in them. How on earth did they get it? Probably it is being transmitted through water. Having said that, today, what is the current prevalence? I don't know the correct answer. When I teach my medical students, this patient has got sepsis in the ICU. You tell me what organism is cruising through his blood. Sir, it can be anything of, yes, I don't care anything, but what is cruising? If you can't tell you what is cruising, why on earth are you choosing an antibiotic? Sir, I want to cover all, I'll give a broad spectrum, covering A, B, C, D, everything, without even thinking. Daldo, whatever is available in the pharmacy. That is wrong teaching and training to the medical student. So if professor does it, all the others will do it. Nobody does cultures. Very few people do cultures. I recommend 3 blood cultures. We don't do. Why? That comes to a separate thing. 7,750 to 2,500 rupees is the cost of a blood culture. So 7,500, much better to treat with an antibiotic. Because my consultation fee is only 450. I am paying the lab 7,500 rupees. Why should we do that? So you see now, in the United States, 18 AMR threats. How many AMR threats do you have in this country? We'll come to that. And in the EU, 16 pathogens are threatening. I think in India, we have more than 25. More than 25. Now, particularly because of hospital-acquired infections. Every time you use an antibiotic, I told you this selection pressure, that antibiotic, whether it's in the newborn or in the ICU, will come out and it will emerge. Who is detecting emergence of resistance? Everybody detects resistance. Who can predict, sir, tomorrow this ward is going to have this particular organism? There is nobody. Nobody is prophesying. But you can see from the consumption of antibiotics in a closed environment, what is the likelihood? Somebody can do a mathematical calculation and say, what is the likelihood of emergence of a resistant pathogen to a particular class of antimicrobial agent. So, you will find, is the organism in the ICU endemic or is it coming from outside? I think it is endemic in the ICU. Next, when you get an infection, are you saying it is coming from is this endogenous or is it exogenous? Most infections are exogenous. Unless I am neutropenic, unless I have got immunocompromised, it's not the E. coli from my gut coming into my bloodstream. It is exogenous. So you try to understand, when you get an infection, is it hospital acquired or is it community acquired? Easy. If I came in from the community, I am shot dead today. I am shot today. What's the organism? Everything will be susceptible to all antibiotics. I think 97% will be susceptible to most antibiotics because I have not taken an antibiotic. Simply because for my ear, they did 10 swabs and each swab grew Providentia, grew Proteus, grew Serratia, and not a single antibiotic I have taken. All it needed was keeping the ear dry. So you see now, if I have to go in for a tooth replacement, the dental surgeon said, "Sir, you are 72 years, you must take an antibiotic." Sir, okay, sir, why should I fight with my own dentist? Tomorrow he will give me more pain. Nah? So I said, okay, sir, give me prescription. And he is giving me amoxiclavulinic acid. I put it in my pocket. I have been taken, even one dose. Why should I take an antibiotic if you have amputated my finger, if you have removed my tooth? Why to take an antibiotic? I can understand if you take one dose before for preventing bacteremia, just like a prophylaxis for endocarditis. So, throat swab, gale mein kitch, ciprofloxacin. Why? Tell me one organism that can cause you a problem with and ciprofloxacin is being used. If you're told you need only penicillin. So having said, you have to see how the hospitals have endemic organisms. Hospitals have organisms that are becoming resistant to antibiotics. That becomes endemic in the hospital next time. So unless you clean up that place again, the same organism is going to come into your next patient as well. So summary update, there are 23 bacterial pathogens. Please remember, any organism that is in your body outside of its natural habitat will be life-threatening, organ-threatening or limb-threatening. So please understand the power and the virulence of these organisms. Now, how do these organisms spread? Now, in the US and UK, the rates are falling. So we have got knowledge that these rates need not climb like it is climbing in India. We can bring it down. If the US and the UK can bring it down, why can't we in India bring it down? So there are care bundles, etc. that we will discuss later. In the US, 2.8 million antimicrobial resistant infections. So we will be having 10 times more, maybe even 5 times more antimicrobial resistant infections. And this drug resistance coming from the community, in about a fifth of them. In India, where does the drug resistance come from? Hospitals or community? You have to decide. Hospitals created, I go into the community, I shed it into the community, I come back again for treatment with you. So you have to understand what this is. So in India, what we have is very little data. So we don't really understand the full epidemiology. I would just like to summarize by saying infections happen in the community. Example is typhoid and Staph aureus cellulitis. Infections happen in the hospital, urinary tract infection, catheter-induced, or skin and surgical site infections, or we have infections in the community coming in like influenza, and influenza getting superadded infections with your colonizing bacteria in your body or from outside. So you have to understand how these infections occur and what is the nature of the organism. It is very tough. So what do? We just follow the West. Acha, they decoded, we must also be having it. But we are not doing surveillance studies. We don't have the money or what. So if you look at it in Singapore, okay, they test the patient before they're coming in. He's got MRSA. Nurses today can't go to Middle East without showing them that they're MRSA negative in their nurses. So the colonization rates, we don't check it because it's expensive. Now is it of value? No. This is how it spreads. In picking your nose and then you spreading it. You don't wash your hands. You don't clean your hands. I shake hands with you. India, that way India's namaste is the best. Okay, you don't have to touch anybody, etc. So this is what happens. So understand the resistance mechanisms. There are beta-lactamase that destroy the chemical. There are pumps which pump the antibiotic outside the bacteria. So if there is no bacterial concentration, no antibiotic concentration within the bacteria, it will not kill. Third one is they are changing the target, they are changing the sites on where these antibiotics can act. And they are having reduced permeability. So if you don't have permeability, then how the antibiotic will enter. So there are ways and means of how these channels can be addressed. So you understand resistance mechanism of bacteria and then try to develop innovative drugs or something to help treat them. Now, what are the organisms that we should be worried about? But WHO has classified it for us. High priority, critical priority, they can be killers, difficult to eliminate. High priority, medium priority. So for me as a clinician, all these are priorities. Why is WHO classifying it in this kind of priority? Now for example, and then I try to look at how they classified it. It's based on mortality, it's based on resistance, it's based on burden on the healthcare system, community transmission. So that is the mind. You should understand when people classify it. I didn't understand how they classified critical priority, high priority, etc. It's on these bases. So what is your high priority in your hospital, in your farm, in your veterinary dispensary or in your clinic? I don't know. What is it? For me, I am very worried about the Helicobacter. Helicobacter, you know, requires triple therapy. Now, if the Helicobacter of a pet, and Helicobacter, please remember, symptoms, ulcer I can treat, but the carriage will result in malignant cancers. So how do I eliminate this organism? For me, that is high priority. Helicobacter pylori. Staphylococcus MRSA, not a high priority for me. So for cows, for mastitis, yes, it is high priority. So you must understand what it is. Shigella, not a high priority for me. But Shigella, if you are going for Kumbh Mela or you are going for any other mass gathering, it is important. So you have to understand what is the importance of all these organisms and how to prevent it, developing vaccines, etc. Now you come to this extensively drug resistance. I showed you those 22 classes. If resistance to all 20 and you got only 2 classes, then you got an extensively drug resistant bacteria. And then what happens? You have got limited toleration. And one of the other reasons why we get extensively drug resistant bacteria, please understand, is biofilm formation. A single bacteria doesn't form biofilm. It is a population quorum that forms the biofilm. None of my antibiotics or the 22 antibiotics will penetrate the biofilm. You cannot kill bacteria in a biofilm unless you do some kind of a mechanical disruption of the calyx. You cannot do that. So you understand. So extensively drug resistant bacteria, particularly in the mucoid lesions of your lung. Pope Francis died of that. He had a testicular lesion or whatever be the reason, etc. You just couldn't eliminate the Pseudomonas and the fungal infection from, he had a polymicrobial infection. You could not eliminate it from his lungs. So you see now, we come to this last resort antibiotic. XDR after that is lab. And I abhor people when they say, sir, I have taken linezolid. Why have you taken linezolid? You don't need linezolid to be taken in the outpatient. Stop it in the outpatient pharmacy. No, sir, doctors want it. Stop it. So you have to use your force. I can use the force because of my position of power as a director of a particular organization. But what about ordinary? Okay, and also because of my age. If you are a young director, nobody will listen to you. I got wisdom, they say, because I got graying and a pot belly, so I got wisdom, I think, on balding. Okay, so tigecycline, cefiderocol. I did work on cefiderocol. It's available now, expensive. But I give this patient cefiderocol. But brother, you have not studied, you have not tested it. How can you do it? Do some reading. Don't misuse that drug. So you will find that India has reached this sad situation, and this is where we stand. You have no option. You have no option. I really don't know in your ICU, I really don't know in your hospital, what is the prevalence of a drug-resistant bacteria, particularly Klebsiella. What is the prevalence of a Pseudomonas aeruginosa, which is multi-drug resistant? with Acinetobacter. Unless you know, you cannot treat the patient. So I have completed this part of it, and now I go to how we can prevent, how we can minimize it. So I have shown you the full problem that is happening in our country. Let's say surveillance, prevention and diagnosis. This I think is pillar number 1. If you don't know, how can you treat? Sir, I don't know if there is a robber or a thief in the house. And how can you, what's the point in putting this thing, sprinklers or putting alarm in your house? You have to find out whether it is there or not. So surveillance in the environment, surveillance in the hospital is a must. Second one, if you know it is there, prevent it. Most importantly is diagnostics. What I mean to say about diagnostics is that rapid diagnosis. Now, when I teach my medical student, I tell them, brother, if you don't give the needle to arm time should be less than 3 hours. In other words, patient comes with sepsis, think, as he got bacteria, think, as he moved from sepsis stage 1, as he gone into sepsis, as he gone into severe sepsis and shock. Whatever it is, I don't blame them, but you must predict. So, sir, I don't have the organism, doesn't matter. What is the temperature? More than 101. Okay, what is the WBC count? More than 14,000. Okay, procalcitonin level elevated. What is the acid? What is the the pH level, lactate level? So more than 4. Okay, give any antibiotic you want. I don't care. But think again before you give that antibiotic. So is it community acquired, hospital acquired? Where is the source? Urinary. There are only 5 sources now. Urinary tract, or is it coming from the blood, or is it coming from the lungs? Is it coming from the skin, soft tissue? Think and choose the. Then you say gram positive or gram negative. Don't think gram positive. Don't worry. 99% it is gram negative, or 95%. You are playing with probabilities. Please remember, medicine is an art of uncertainty, and you are playing with probabilities. What is the probability of raining? Yesterday I didn't think of rain yesterday. Torrential rain yesterday. So you have to look at the probability and then choose it. As he got comorbidities, he is hale and hearty, he is 80 years old. You may change your decision making later. So please remember this, you got very limited time. The longer you delay in starting antibiotic, the greater the mortality. So that is why when you have that kind of a situation, I need accurate. Otherwise, why I need to? If the microbiologists don't grow any organism for me, what is my respect for them? It's not their fault. It's not growing. They are not doing anything to make it not grow. They are only singing songs, grow, 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 and making it grow. But if it doesn't grow, why fault them? Then my thinking goes into this, I am not sending culture because they are not growing. Only 15%, 20% of the blood cultures yield a particular organism. So they get dismayed. And you tell me, treat. If the microbiologist tells me what to do, I will do. But if the microbiologist does not know what they are growing, then it is my call. So you need rapid tests. You need rapid identification test. Can you do for me 16 sRNA? Fatafat. I'll know whether it's bacteria or not. Can you give me the result in 1 hour? I won't use antibiotic. You are not giving me 16 sRNA, and then, sir, will you pay? 16 sRNA costs only 275 rupees for the primers. When you will charge me 2,500. Will I pay? No. You see, it's diagnostic and cost. So you must understand that. And then clonal relatedness. Ma'am, was this organism present in the ICU last year? I don't know. Only the antibiogram will tell you. Tell me the genome. That means I know this guy is still working in the ICU. I will clean. Nobody is giving me data. In the US, an organism like that, they will send the Army, Navy and the Air Force. We did it for Operation Sindoor, but we won't do it for the operations for the organism in our ICU. So you must understand that. So I cannot select the right antibiotic. Next one, okay, gold standard. Even after you get the organism, you are not able to give me the MIC. You will give me disc diffusion, good enough, 95% better than other. But what if it is resistant to carbapenem? Whether you use ertapenem or meropenem, I am not bothered to detect the carbapenem resistant. But what if it, which of the carbapenems? What drug I have to use? If it is a metallo-beta-lactamase, are you detecting it? I can't. You don't. So I give combination therapy with all the drugs that I know of. So you see now, what is your gold standard? You have to get rapid molecular tools. If you don't get rapid molecular tools for me, I am not going to respect you or the microbiology lab. Now, I got drugs. Pharmacologists have given me drugs, but I cannot use it properly. I will create selection pressure and worsen my ICU pathogen if I don't have it. Cefiderocol, or you got ceftazidime, avibactam. So what happens in high-funda hospitals? Money is important. My revenue per occupied bed must be good. I'm not worried about that. They give any antibiotic you want. My CEO will say any antibiotic is allowed, but save him. So we continue. So now you look at this. Tell me, cost of doing a blood culture. I calculate. I run a lab. Honestly, I run a lab. I put in my life savings, 2 CR, into my lab. I'm not breaking even. I'm losing money. It costs me only 275 rupees to do a blood culture, but I have to charge 1,200. Otherwise, I will not get my overheads. I don't get more than one blood culture sample at a time from a patient. I looked at the workings. It costs this much money. You can say 275. How much can I pay the microbiologist? 80,000. The medical colleges, 150, maybe 2 lakhs a month. How will I recover the cost? So you will understand all this. And then once you grow an organism, what is the resistance? Again, it costs money. If I use the Gene Expert, I got Gene Expert. I got NAT. If I use them, minimum I have to charge 1,500. And I have to give them the, I don't have sequencing. If you do sequencing, that's only for research. I don't need sequencing for daily work. So you understand cost. You can talk big and say AMR to be prevented. So Government of India, will you subsidize my cost for cultures? You give me this thing, export duty, import duty, whatever it is, you cut it down. Now this is the costing. And my lab must have at least 1,500 specimens per month. So no medical college lab has. And if they have 1,000, they are growing maybe 200 organisms. And are they preparing antibiograms? And what is the panel they are using? 6, 12, 18, 180 millimeter disc, whatever, this thing. Nobody is concentrating. Don't blame the clinicians. Don't blame the physicians. We are not spending on this diagnostic thing. Training competencies. I spent 4.5 years MBBS. I spent 3 years MD, general medicine. Same thing the microbiologist also spends. Why? Their training competencies are different. I am not challenging. I am not saying they are lesser than the physician but the physician sees the patient eyeball to eyeball. Sir, I cannot tell the microbiologist is not growing. If the microbiologist grow, I will tell you. Do you think the patient will believe you? That is the training competency. They are not in communication. I am in communication. They are in public health. They are in research. They are good in hygiene. I am poor in all of the above. So you see now their training competencies are different. And I can evaluate differential diagnosis. If they say it's not infection, then what is it? I don't know. But I can evaluate non-infectious causes. That's the difference. If they ask the spelling, if they ask UCAST values for CLSI values, doesn't matter. What's the spelling of UCAST to a physician? All I want to know is susceptible or not susceptible. So that is the situation. I need early diagnosis, I need quick diagnosis, I need accurate diagnosis. Only then can I choose the antibiotic. Otherwise, what color shall I wear today? I got brown today, okay, tomorrow what I am going to wear, what antibiotic to use. That will be the problem. That is the problem today. So therefore, after having talked about the microbiologist, I am going into the pharmacologist, which is the antimicrobial stewardship practices. If you don't have proper stewardship practice, then you cannot. So what is the stewardship practice? I prefer narrow to a broad spectrum. Aware. We teach medical students aware. A is for access, make sure that they get these antibiotics, amoxicillin, cotrimoxazole, and cefazolin. Okay, 60%, 70% you can manage with that MBBS guys. Then who's the watch? The watch ones are the quinolones, the meropenem. Don't touch it, MD guys. Only the MD guys can use the ball. That's how I teach. You use any of these, but don't touch these aware, the WA. I watch it. Then reserve, never, only DM infectious disease. Don't touch a reserve antibiotic. How can I teach like that? Sir, I got MBBS, I got license, you also got license, I will use. You cannot control. How can you control them? So what is them? Only in a hospital situation I can control. I can only plead with them, Anna, Kana, Manda, Tavel. Come to that stage. I can't crack a whip. Then it's okay, you transfer the patient in your name. Okay? So you see the problem. Aware is nice, classification. I can teach antimicrobial stewardship, all these things, training, education, formulary, guidelines, all of those I can do. But show me a hospital that it's being done. Okay, I looked at hospitals, not many in 2013. You're talking about NABH associated institutions. How many are there in this country? Non-NABH. You can't do. And even NABH doesn't say anything about antimicrobial stewardship. Even the 6th edition. I will speak to the quality control. Why are you saying that you are giving NABH accreditation to a hospital that is creating multi-drug resistant organism? Remove it. Nobody has the guts. Nobody has the guts. At least the hospital CEO should be interested. Don't create an MDRO. Don't transmit an MDRO. That's my job. That's my job. So what we did, training and education. Now you see, National Action Plan is there. The Medical Commission is there. Come on. See, you see the situation now. National Medical Commission, when I was the dean of the medical college, was my boss. Not my shareholders, not my employers. My boss was NMC. If they say jump, how high, sir, should I jump? Today, NMC has got Tamil Nadu medical colleges, 34 out of 36 not ready for functioning. That means they are going to be de-recognized. Show me your faculty. So NMC can issue notices with teeth and without teeth. Without teeth, what can I do? Practice. Will I pass the exam? If I don't do NMC guidelines, I will still pass. So you need a regulatory framework. And all this other is good. And how this WHO essential list, it is there. But who is translating it to your formulary? Okay, and surveillance system, hospital formularies, stewardship guidelines. I have got it in my own hospital as well. But who is stamping the feet and saying, brother, you follow that, otherwise your payroll will get cut? I don't say that. Okay, so aware matters. Now you go to the infection prints, IPC. And I've got a series of slides, but you don't need to go through that. First, number one, there are only six points that matter in infection control. First and foremost is hand hygiene. Make sure at least before you touch the patient and after you touch the patient, you at least do some hand hygiene. That is a must. Second one is antisepsis. If I'm going to put in a needle in you or put a catheter in you or please wear a mask. Not to protect you, but to protect yourself and the patient. Wear a gown, PPE. So proper antisepsis. So you don't transmit infection. Hand hygiene, then proper PPE, no problem. I can do these two, sir. Because I can kick you if you don't do that. I can cut your payroll if you don't do that. Under my control. If I don't give PPE only is a problem. The third one is sterilization and disinfection. Sterilization and CSSD practice. I ask the nurses, please make sure whatever methodology you do, it must be sterile. If the pack must not be open, sterilization and disinfection, yes sir, I will take care of. Fourth one is environmental cleaning. Clean, clean, clean. Who to clean, how to clean, where to clean, why to clean. They must keep it clean. You should not say, my hospital is smelling nice. No, I'm not interested. Aesthetically nice. No, I'm not interested. Are you microbiologically sterile? The fourth one is in terms of care bundles. Care bundles. And the sixth one is the antibiotic care bundles. But I'm talking about care bundles of long line, urinary catheters, etc. So, if you handle this, no hospital infection will occur by transmission. So, AMSP you have understood, infection control principles you have understood, and then diagnostics you have understood. These are the three pillars of making sure that you do not have any hospital acquired infection. Okay, now I'm just running through the slides because I will be lacking another 6 more minutes I have. So, now restriction. In the antimicrobial stewardship principle, restrict, we have already spoken about it. Restrict, don't give powers to them to handle this. Decolonize if you can. Cohort them if you can. In a NICU, how do you cohort? Very difficult. When I went to Breach Candy to look at how the elite mothers were transmitting staphylococcal infections to their breast, I found that dyes were transmitting because they had to express the milk. MRSA, same clone. So you can do studies, that's all fine, that's not the thing. But restriction. In India, we just take it a chance. Put it, it won't happen. But you should understand the pride. We don't get vancomycin resistant organisms simply because we don't use too much of vancomycin. So look at the antibiotic care bundles. Diagnosis again, and have a policy, switch from IV to oral, solve the disease, don't worry about that. This is a clean, so many touch points to be cleaned in the ICU. Okay, you can have my slide presentation. I'm going through it very fast, but you can keep it so that you can understand it better. Okay, now you can have no touch disinfection, hydrogen vapor, GTO, UV light, your cost is on this. If you don't do it, patients will start doing this. Next door patient will have armed military guns and then you will take care of themselves. Okay. Now, clean. Acinetobacter baumannii is not a commensal in your organism, in your body. Then where on earth is it coming from? Environment. So very hardy organism. Clean. Otherwise you cannot get rid of Acinetobacter. US doesn't have Acinetobacter baumannii. Australia doesn't have. Same human Homo sapien race is there. Why? We are not cleaning our hospital. Brazil has got. Okay, why to clean, when to clean, how to stress the importance of cleaning. Make sure who is following up this cleaning. If you go to the restroom, there will be one tick mark. Is the bathroom clean? Smiling, while smile face, this, that. That's aesthetically clean. But microbiology clean, are you doing surveillance? Okay, all this, every time it's a problem. I tell them I'm paying you square inch clean. You have to be rough and tough. Here you cannot be anakana. You have to be rough and tough. It has to be military precision. So you have to have like a bulldog. If you don't do that, you cannot ensure that your hospital will be clean. I want NABH to say 6th edition or 7th edition, this hospital is free from any multi-drug resistant organism. Just like you said, no accident occurred in 1 million working hours. No pathogenic, no MDRO was detected in the last 1,000 patient admissions. If you can put it, now you don't need to spend any money on advertising branding. That word is enough. 10 hospitals in India where there's zero infections. Everybody will come. Everybody will come. The CEOs are not looking at it. Prevent infections, typhoid. I eat street food. I love street food. I'm only worried about typhoid. So I'm not worried Shigella, I'm not worried all the self-limiting. But typhoid, I take typhoid vaccine. Now I can eat, but I still won't take chutney, I won't take pulpy fruits. But I will, because inoculum may be high. But the hot vada, this morning I had hot vada, very good. Okay, and I tell everybody, wherever, not here alone, anywhere, even to my own, please wear a plastic glove before you touch my food. And otherwise, how can I touch your same thing going into my mouth? It's not aesthetically, no, microbiologically. Because you don't know after I give you the water, I give you next water. Where all the hand touches. Okay. So I have vaccinated myself, pneumococcus, influenza, that's a separate class by itself, I'll speak to you later. So many unresolved issues. So this is the interdisciplinary work. Okay. Now, I am not up to date. Sometimes I don't know what the susceptibility pattern of this organism, what next best. And there are so many antibiotics now available. You can pay import duty and buy. Previously, on humanitarian grounds. But you have to still get permission. Now we have challenged him. Who is the drug controller? What right has he got to give me one drug if I pay for it? So, sir, okay, sir. Okay. The court of law has said, you cannot prevent Dilip Matai getting one drug for one patient. He is saving a life. You charge customs duty, I don't care. So, you can't control. So, you see that you can import any number of drugs now. So, if you have a variant organism, you can even import for that. So, you have to monitor and control the dissemination of new variants. But challenge is there. The rural wala, sir, Dilip Matai, sir, if you use that drug, we in rural wala, if we get that infection, who will pay for us, sir? So in a way, in a democratic society, it is correct. I can't challenge, he can challenge. So it's very difficult to handle this. Pharmaceutical pollution. Now what I am saying is, we prevent the use of colistin in the veterinary. This article is coming out 2025. Okay. Is it right or wrong? I don't know. Now, pharmaceutical pollution in Hyderabad, in rivers, etc. The antimicrobial agents are getting into the water. My own hospital, I don't treat the wastewater. Where the large amount of antibiotics that I am using will get eliminated in my wastewater in the hospital and it will flow into the sea. Who is doing pollution control? Leather industry, pollution control. Antibiotic industry, no pollution control. You see, all these have to be understood. AMR in the One Health context, yes, I am aware of the classification, the animal health antibiotics were drugs, and I prepared a summary table of any use of drugs in animals and humans. You have to, not you, I have to stop using your antibiotic, or you veterinarians will have to stop using my antibiotic. Who is a bigger force, mankind or animal kind? It's a big philosophical question. So at least you reserve some of my drugs, that is the last resort drugs like colistin, and not to use it for this. So my last slide will give you the summary of all the strategies that you need to follow. Thank you very much for your patient listening.